So I will next 7 or 8 minutes, I'll talk on SGLT2 inhibitors. As you know, these drugs are considered as a miracle drug of this century in diabetes and cardiology. These are the drugs which are the glucose co-transporter 2 inhibitors, which cause loss of glucose absorption, reabsorption from the proximal convoluted tubule. SGLT2 receptors are the main receptors for this. They are also present in SGLT1 receptors, and there are now newer SGLT2 blockers which have come, which block both 1 and 2 receptors. So SGLT2 is a novel insulin-dependent drug which acts independent of insulin, causing excess of glucose excretion, loss of weight, and loss of calories. If you look at here, the HbA1c reduction over and above metformin is close to around 0.7 to 0.8 gram %. Weight loss is somewhere between 2 to 4 kgs. Systolic blood pressure reduction by around 5 millimeters of mercury, and the diastolic blood pressure reduction by around 4 millimeters of mercury. Let us start with the CVOT outcome trials. If you look at patients with diabetes, the first trials all took in patients with diabetes, where it started with empiric outcome at Stockholm in 2015. This showed early and sustained reduction in cardiovascular death by close to 38%. This death reduction in empiric outcome was in fatal MI, fatal stroke, heart failure related death, sudden death, and presumed cardiac death as well. Also, the death reduction was irrespective of single vessel disease, multivessel disease, history of CABG, or prior MI, and irrespective of whether the cardiovascular disease was peripheral artery disease, stroke, prior heart failure, or history of atrial fibrillation. The reduction in terms of myocardial infarction was around 21% relative risk reduction in myocardial infarction. So the lessons learned from these trials, which are empiric outcome, Canvas program, Declare TIMI, and Vertis, was the MACE reduction was shown by empagliflozin and canagliflozin, cardiovascular death only by empagliflozin, heart failure hospitalizations by all the 4 SGLT2 inhibitors. There was, of course, a heterogeneity amongst this as far as MACE was concerned. In the secondary prevention cohort, only Canvas and empiric outcome showed reduction in the MACE. Vertis CV was a neutral trial. Declare TIMI showed the trend towards it, but not statistically significant. In patients without ASCVD, of course, only in the Credence trial, canagliflozin showed significant reduction in cardiovascular death and the 3-point MACE. When you talk of renal outcomes in this trial, across the board, all the SGLT2 inhibitors showed reduction in more than 40% decline in eGFR, progression to end-stage renal disease or renal death. Then let us talk about CVOT in CKD. Credence showed that in patients with diabetes and diabetic kidney disease, doubling of serum creatinine, death from kidney causes, cardiovascular death, they all got reduced with canagliflozin. Then came DAPA CKD. This was a trial in diabetic as well as non-diabetic patients with diabetic kidney disease and non-diabetic kidney disease with reduced GFR and USCR of 950 average were randomized to dapagliflozin. And dapagliflozin showed significant reduction in heart failure hospitalization and even all-cause mortality. So, what are we talking about here? We have a drug which is actually an anti-diabetic drug, came into the market as anti-diabetic drug, but it showed reduction in cardiovascular death, heart failure hospitalization, 3-point MACE, and even renal outcomes in patients with CKD. What about heart failure? Heart failure, the first trial was DAPA-HF. Trial with reduced ejection fraction, elevated NT-proBNP, and eGFR above 30. Randomized to dapagliflozin versus standard of care. What was standard of care? Standard of care was 96% of these patients were on beta blockers, 94% were on diuretics, 94% were on RAS blockers, 20% were on RD, and yet dapagliflozin add-on showed 26% relative risk reduction in CV death, heart failure hospitalizations, 18% reduction in CV death alone, and 17% reduction in all-cause mortality. What is extremely important in DAPA-HF, that this benefit was irrespective of diabetic status, diuretic therapy, background therapy with ARNI, across the ranges of GF from 30 to 90, and irrespective of heart failure etiology. Also, the CV death and heart failure hospitalization was significantly reduced. Earlier, the patient was admitted with heart failure hospitalization. So if the patient has recent hospitalization, more the benefit. Remote hospitalization, less the benefit. Then Emperor Reduce came. Similar trial, similar group of patients, excellently treated with background therapy. Empagliflozin showed 25% reduction in composite endpoint of CV death and heart failure hospitalization. But importantly, the slope of decline of eGFR was reduced by 50%. And this new article, which was just released 3 days ago in European Heart, 3 days ago, showed that dapagliflozin in DAPA-HF trial showed benefit in ventricular arrhythmias, cardiac arrest, and sudden cardiac death. So for DAPA and Emperor Reduce, the trial of hurdle was formidable. The drug has to show benefit over and above RAS blocker, beta blocker, MRA, and ARNI, and it yet showed benefit. So it was a humongous victory, a phenomenal victory of these drugs in heart failure with reduced ejection fraction. Then came the renal endpoint in Emperor Reduce, 50% reduction in progression to end-stage renal disease. In 2021 ACC-AHA, we have soloist and scored trials with heart failure with preserved ejection fraction with sotagliflozin showing clear benefit. And then we have Emperor Preserved, released just 3 days ago, showing significant benefit in heart failure hospitalizations in patients with HEPPEP as well. So now these drugs have proven their point in heart failure with preserved ejection fraction as well. So the breakthrough results of empagliflozin have been now clearly established in HEPPEP as well. And therefore, Milton Parker and John McMurray say this is the fantastic four: MRA, ARNI, SGLT2 and beta blockers. Fantastic four for 4 pillars of treatment of HEPREF. And now empagliflozin in treatment of HEPPEP as well. The potential mechanisms are many, but the main is osmotic diuresis from the interstitial compartment without contraction of plasma volume. And many other mechanisms, we all know them. I will not spend a minute in this, but the most important is reduction of arterial stiffness, persistent low-grade ketonemia, natriuresis and osmotic diuresis, reduction of sympathetic activity, and weight loss and visceral adiposity. So what is new? New is they are considered a first-line drug in patients with HEPREF, patients with proven ASCVD in all the international guidelines, including ESC, Canadian Cardiovascular Society, and American College of Cardiology. The KDIGO guidelines 2020 also show that SGLT2 inhibitors are first-line therapies in patients with CKD, diabetic or non-diabetic with reduced GFR. And the proposed modification of algorithm of HEPREF now involves SGLT2 ahead of ARNI in patients recently discharged or about to be discharged with acute decompensated heart failure. So the CAPTURE study has shown us, a registry has shown us that 1 of 3 people with diabetes have established cardiovascular disease, but only 2 out of 10 people with type 2 diabetes and established ASCVD are getting glucose lowering treatment of proven cardiovascular benefit like SGLT2 or GLP-1 receptor agonist. So now is the time to act. And I feel we all should come on one platform to start these drugs in as many deserving patients as possible. Thank you.